We'll go ahead and get started. Thank you, everybody, for taking some time out today to talk about or to hear about our pediatric diagnostic test battery in the world of audiology. My name is Sanchez. I go by Chrissy. I'm a pediatric audiologist at the University of Miami Ear Institute. Just to give a little brief on the Ear Institute and what kind of services we provide. We are a multidisciplinary otolaryngology department. However, our Ear Institute is comprised of 6 neuro-otologists and then a very comprehensive pediatric program called the Children's Hearing Program. I only allude to this as though because our clinical cases are not necessarily your run-of-the-mill fluid, ear infections, snoring cases. We do have a general ENT clinic that some pediatrics go see, but that's not housed in our Ear Institute. So we do really see multiply involved, very complex cases, which makes audiology just that much more interesting and testing them that much more difficult. So this is just really a chronological review of how we test children. So if you were ever wondering what, the audiologist was doing for an hour in the booth, maybe, this maybe will give you some insight on that. So before I talked about anything related to what we're doing clinically today, I did want to give an ode to Dr. Marion Downs, who did a very, very great efforts in the 60s to get newborn hearing screenings on the table. She was really pioneered. She's really considered I don't want to say the grandmother of audiology, but the pioneer of pediatric audiology, and why testing and early intervention is so important for these children. She really just had to hone in the impact or the negative impact of untreated hearing loss in children, especially prior to 6 months of age. And so she really helped pioneer the Joint Commission on Infant Hearing Position Statement, which stated that we needed to identify hearing loss before 1 month, diagnose the hearing loss before 3 months, and treat or intervene before 6 months. So if you think about the baby's first 6 months of life, that happens in a blink of an eye, and we're supposed to get these children aided or in appropriate amplification options before then in order to minimize their delays and to get them caught up with their normal hearing peers. And this is Marion Downs. She unfortunately passed away in 2014, but really all of the strides that we've made to get universal newborn hearing screenings across the nation in place have been a testament to her efforts. So on to that, we're going to transition to our otoacoustic emissions. This is the most common newborn hearing screening test that is done in the hospitals. Every hospital in every state has their own guidelines. So wherever you are, you may think, well, what I'm saying is maybe incorrect. I'm coming from the state of Florida. Unfortunately, Florida has a reputation for doing things sometimes backwards. So we may not be doing things the best way, but more common than not, most hospitals implement a 2-stage screening in that they will first run an otoacoustic emission on a child. And this can begin just days old. So this is really great tool. We can do this fresh after being born, probably not advised, but still can be completed. And there's different types of otoacoustic emissions. Clinically, there's transient evoked, there's distortion product, which I'll talk about today. There's spontaneous otoacoustic emissions. These are really just responses generated from the outer hair cell motility, electromotility in the cochlea when they're stimulated simultaneously by 2 pure tones, which we call our F1 and our F2 frequencies. The mechanism behind it is that the electromotility based cochlear amplifier is responsible for the movement of the basilar membrane at the center frequency, causing this deflection. And clinically, really, these techs are going into these birthing rooms and they're telling the parents, we're just picking up an echo. And that's what they're kind of calling that deflection. There's a soft sound. So if you've ever had an OAE run on you, it's a very, very faint sound. And that machine is picking up, quote unquote, that deflection or echo. Now, this can be done in 2 capacities. This can be done as a screening, which is often done in the hospitals. And this really just gives us a pass or refer. It really doesn't give us too much of a diagnostic insight on what is happening with those outer hair cells. It's just telling us that there's a really great emission being produced by the outer hair cell, or there is not a very strong emission, and further testing is needed. From a diagnostic standpoint, we have a lot more manipulations that we can do. We can assess for our center frequency. We can look at our emission strength. And then we can compare that to the noise floor, so the ambient noise floor around the patient. And then we can look at the difference, so the signal to noise ratio between the two, to see how strong is that emission compared to the noise. And it is important to note that, how I mentioned before, there are other OAEs, but all I wanted to really brief here is that DPOEs are not a measurement of hearing sensitivity. So unfortunately, the crux of OAEs, while they're very easy to complete, especially in a screening mechanism, this takes less than a minute to complete if the child is asleep, which most infants after birth are. Unfortunately, these present and robust OAEs that we can get as a passing response actually really can't rule out a mild hearing loss. So if clinics are only implementing an OAE screener, we can have many children around with maybe a mild hearing loss that these DPOAEs are not sensitive enough to pick up. So that's really the caveat of OAEs. Now, I will say more often than not, at least anecdotally, if you do have a child that has a mild hearing loss and still has present OAEs, some of them are usually by either reduced or absent. So there's some indication that something may be not as healthy as it should be. But when you have techs going into hospitals, they're not really interpreting the data. They're just getting pass or fail. And so that's really kind of the one caveat of this test. It's very fast, very easy, very efficient, however, can miss this small subset of children. Other hospitals, as a second stage screener, so if a child were to fail an OAE, they may be then referred to do an auditory brainstem response. This would be a threshold auditory brainstem response. There are different ABRs that we can complete for different reasons. Sometimes in the adult world, they complete ABRs to rule out some retrocochlear pathology prior to imaging, of course. But in the baby world, we do it to obtain actual threshold measurements of their hearing sensitivity. So the reasons why we would do ABRs on children would be obviously the biggest one being a failed newborn hearing screening. Sometimes children will pass their newborn hearing screening, but they have a family history. So we would still want to go dive a little bit deeper and get an ABR on those babies before 6 months. If they have an extended NICU stay, that increases their risk factors for hearing loss. Just being in the NICU for over 5 days is an increased risk factor for hearing loss, plus all of the treatment that could occur in the NICU only increases your chances of having hearing loss. If the parents become concerned for hearing loss under 6 months of age, and then we can also perform ABRs on patients who have special needs, multiple needs, developmentally delayed patients, special needs adults, really anyone who can't perform behavioral testing. So somebody who can't comprehend the task that we're trying to do in the booth, we could always perform a threshold ABR on those patients as well. There are two aims to performing an ABR. One is to obtain a frequency and ear-specific threshold. So we want to know the thresholds of hearing sensitivity in the left ear at 2000 hertz. Most ABRs have the capacity to test about 500 to 4000 hertz. Depending on the manufacturer and the equipment you have in your clinic, this may vary. In our clinic, we can test 5, 1, 2, and 4. And then we can also test bone conduction reliably at 500 and 2000 hertz. So we're even able to assess if a patient, even at infancy, has a conductive hearing loss or a sensory neural hearing loss. What we look for when we're looking at these squiggles is we're identifying a wave 5, and I will talk about waveform generators in just a moment as I continue talking about ABRs, but we're identifying this slope, this obvious waveform that not only repeats, so you see these two tracings that have a clear repetition of a slope right here, but as we decrease in intensity, so this one was run at 45 dB, and as we decrease, well, that was a little typo, and we drop down to 35 dB, we see this shift, the latency shift, and it should become a later response. So as we get louder, the response should become earlier, and as we get softer in stimulus, that response should shift later. That's really our telltale sign of identifying a true kind of threshold response, a true auditory response, and we can rule that out compared to maybe artifact if the child is moving, so to speak. We can also identify, significant hearing losses. So in this case, this was done at 105 dB, and you can see that this side does not look like anything like this side. We don't see any repeatable slopes. And so this is actually an ABR of a child who has single-sided deafness, and we were able to diagnose this at 3 weeks old. The other thing that we can do with ABRs is we can actually assess neural integrity and the synchrony of the cochlear nerve using a very high intensity stimulus, and we usually use a click stimulus at this age. Sometimes you'll see these squiggles in your ABR reports, which will give you a lot of identifiers. We have wave 1, 3, 4, 5. Sometimes we even identify wave 2 if we go loud enough. So the basics of this test is really, we want to assess that synchronous electrical activity that's generated from the cochlea as it passes through the nerve and then enters the brainstem in response to a very loud auditory stimulus. Our waveform generators, if we look at more of a textbook response, we have waves 1 through 5 that we should be clearly identified when you're presenting it loud enough. So in this case, this is an 80 dB stimulus, and these are wave 1 through 5. Although this is clearly wave 2, this is wave 4. We just normally in clinical practice are only identifying 1, 3, and 5. And as you can see, as they drop in intensity, the amplitude of these waves 1 through 4 are diminishing, but waves 5 continues to be the most prominent waveform, which is why as we search for threshold, we search for that wave 5 response, because the response from that lateral lemniscus as it enters the inferior colliculus is the most robust response from the auditory system. It's the latest response that we're looking for. If we look at more of a clinical example, of course, then we can see something like this. Now, to give you an idea of what we do when we are presenting this ABR response, we often present the stimulus at both 2 different polarities. And this is just really air conduction polarity. So we send the signal in a rarefaction, which is, it starts negatively, and then we can send it in a condensation polarity, which is, it starts as a positive. The diaphragm of the headphone is starting in a positive interphase. And what we should see is when rarefaction and condensation are placed on top of each other, we should see this nice synchronous response. Sometimes we can also use a third polarity, which is an alternating polarity, which is just the combination of a positive and a negative, which should just actually equal each other out. So to give you an idea, if you see here, this is a rarefaction response and this is a condensation response. This here is when we just put them on top of each other, and you see this really, really unique sinusoidal response. And this response is something that we look for as we continue to do ABRs, because this response is called the cochlear microphonic. Sometimes this response is expected, and sometimes it can be a very, very large red flag. The cochlear response is actually a pre-neural potential that's generated by the cochlea, and it usually mimics the stimulus waveform. So we're actually generating a very, very loud sound, and the cochlea is driving this stimulus, and we usually see it before 3 milliseconds, and that's usually a healthy cochlear response. This may be visualized with normal hearing individuals. So in this case, this is a normal hearing ABR. This is great. However, I must segue into when a cochlear microphonic is not normal. And that's when we're able to identify a concern or a diagnosis called auditory neuropathy spectrum disorder. Now, this is just the ABR. When we talk about our ANSD population, is just one of the parts of this diagnosis, but really one of the big foundational diagnosis standpoints in this diagnosis is that robust cochlear microphonic. And when I mentioned that third polarity that we can run alternating, that's how we can rule out if this is a robust microphonic or if it's just stimulus artifact. So when this cochlear microphonic ends up looking something like this, or it actually rings out the entire duration, that's a huge red flag. So that cochlear microphonic, like I mentioned before, should only be present before 3 milliseconds if this is a normal hearing child. When you see that cochlear response ringing out throughout the entire duration of what we're assessing, that ABR potential, we know that something's maybe not right. So in this case, we ran our rarefaction, we ran our condensation, and we put them together, and you see this sinusoidal response ring out all the way to nearly 9 milliseconds. When we run our alternating polarity, which is right here, you see this flattened response, which tells us that this is actually not a neural response. This is a response from something else, which we know is the cochlea, and this is actually telling us that there is no neural synchronicity. There is no neural response here, and we often then will pinch the tube of the transducer to confirm that it's not artifact. So these two should be fairly flat when you're comparing to these 3 tracings. This here is a huge red flag when we're conducting an ABR, because it tells us that something's not right with that nerve. Now, other characteristics to diagnose ANSD via an ABR is that when we run those tone burst responses, like we talked about before, when we're looking for thresholds, we usually get no measurable response. If we do get something that looks like a response, it's usually abnormal in morphology, or it does not shift with latency. So we'll see this kind of same response happening at the same exact time frame, which is not normal. These children will have present or partially present DPOAEs, which is largely the reason why this cochlear microphonic is so robust. It's generated by that outer hair cell motility, so it's not necessarily representation of a nerve-related response. This is just telling us that the cochlea is working, but for some reason the nerve is not responding. These children will have absent acoustic reflex thresholds. And then we kind of have to transition into their behavioral testing. The crux of these ANSD children is that the ABR is going to tell us that they have a profound hearing loss or they have no measurable hearing. But really, the reason why this is called a spectrum disorder is that children behaviorally, when we put them in the booth, can have anywhere from normal hearing sensitivity all the way to a profound hearing loss. So it is very important to kind of disregard the ABR. Obviously, focus on the medical management that's needed, imaging being the first recommendation that we make for anyone that we identify this via ABR, but we have to put them in the booth as soon as possible because these children can functionally sometimes hear very normally, but for some reason their nerve is not firing the way that it should be. And typically, if children do have measurable hearing and they have ANSD, we do see this weird pattern that we would see with patients who have maybe more of a retrocochlear pathology. So anytime we're looking at things like rollover, so for patients who may have tumors on their nerves, we'll see that they have really good hearing, but when you actually present a stimulus loud enough to saturate that neural response, their word understanding really degrades. So they can hear things, but they don't quite understand what they're hearing. And that's one of the telltale responses of a child with ANSD as well. And if they can understand things, they definitely start struggling to understand more things when noise is presented. So this is even more so than a traditional patient who has just our typical sensory neural hearing loss. Now, obviously, by its name, auditory neuropathy would imply that there is no nerve, maybe an aplasia of a nerve. And this is not the case in majority of cases, but as an audiologist, when we see this pattern on an ABR, we immediately refer to our neurotology team, and they typically will get imaging, usually as close to 6 months as possible. And if the nerve is there, but they're still presenting in this capacity, then we deem it more being a dyssynchrony where the nerve is intact, but the actual neurons are not firing. Whereas sometimes these kids could also present with a cochlear nerve aplasia. So really just tying into that spectrum of children that we can see when we have this one diagnosis. And it's really a testament to early identification, and it's really incredible that we can see something as severe as a cochlear nerve aplasia as early as, weeks old via an ABR to kind of raise these red flags and really provide children with the early intervention they need to be successful. So really kind of tying into what does this mean? Is the nerve present? Is the nerve present and there's just a dyssynchrony like I mentioned before? Is this maturational? So sometimes with our very premature babies, they present with this kind of cochlear microphonic, but then when we test them 6 months later, the microphonic is gone, but they are truly just profound. So it's really important to repeat testing. Is it genetic? So there's a lot of children, at least we have in our clinic, that we refer for genetic testing, and then they come back with having a mutation in the otoferlin gene, which actually mimics itself as having auditory neuropathy, which this may be best case scenario because their nerve is actually intact and it's more of a genetic mutation. But this information is very important, and making sure that we make appropriate referrals is really important really early because this guides our management options. So this will tell us if the child is a hearing aid candidate. It will also tell us if a child is a cochlear implant candidate with positive possible outcomes. So if that nerve is present and intact, we can probably assume that they would be really good cochlear implant candidates. However, if that nerve is not visible, then, or maybe we only see a wisp of a nerve or they're unsure, we may be aggressive enough to proceed with cochlear implantation, but we would set that family up with very maybe poor, unpredictable outcomes. We wouldn't necessarily set them up for as much success and maybe only expect sound awareness, if anything. Or in cases such as severe cochlear neuromalacia, common cavities, although most clinics are still aggressive enough to try and intervene with cochlear implantation, that may put someone in a position to say they're not a cochlear implant candidate for whatever reason, and they need to pick up more manual or oral manual communication to develop their speech and language through that capacity. So lots of decisions are made based on this one diagnosis really early on. And I want to kind of transition now to the booth. So when we have this child with ANSD, we have to get them in the booth, like I mentioned, as soon as possible. And we can do that really, really young, but it's not really that reliable. For the next few slides, I actually wanted to showcase some videos that we've taken of our patients. We have permission to do so. They've all signed their releases. And I'm going to do some self-polling questions. So I'm not going to ask anybody to put their answers in the chat, but just a self-questionnaire because I like to make this as interactive as possible. So our first test that we can do in the booth as early as less than 6 months really is behavioral observation audiometry. Now the jury is out there on whether this should be called behavioral observation audiometry or just behavioral observation. And I just don't like using things with the acronym of BO. So I'm on the train of behavioral observation audiometry. Now, I understand the crux of it is that it's truly not an audiometry-based test in that it's more observation. So we usually do this on children who their ability to turn their head is underdeveloped, so children who are very young. We sometimes have to perform this test on patients who have motility issues, such as patients with cerebral palsy, some paralysis, and then sometimes we have to perform this test on children who have autism who are refusing to do anything but may give us an eye blink or an eye shift. And so those really small and subtle behaviors are what we're looking for. And so the goal of this test is to observe a variety of behaviors, such as either a sucking response. So sometimes we'll have infants feed, either breastfeed on the bottle or give them a pacifier, and we'll play a sound and we notice that sucking cessation, which is a really great indication that the child is obviously a change of behavior, usually a response to that sound. A startle response, so if we want to know if a child is profound, sometimes we will, in extreme cases, just crank up the volume and play it and see if they startle. That's a really good indication that the child may not actually be profound. Sometimes with those special needs adults or adults with mobility problems, they'll give us eye blinks so they can comprehend what they need to do, but they physically can't actually do it. So they'll give us consistent eye blinks. They'll tap or twitch their finger. Or in cases of children with autism, sometimes they have an adverse reaction to what we're doing. I only know this. We tested a child. She was a teenager and didn't do anything for us. She just sat on the chair. And the dad told us to sing happy birthday to her because she really gives us good responses to singing. What he did not tell us is that she's actually terrified of the happy birthday song. So every time we would sing, she would jump out of her chair and just run across the booth. And that ended up being very much a torture experience for her. But we did get really good, reliable hearing responses, at least to speech sounds for that child, to at least deem that she had access to normal hearing related to speech sounds in that case. But, you know, sometimes we're desperate and we have to do what we can with these children. And I do want to note that this testing really never reveals a threshold. So we're not getting the softest sound they can hear. If any of you have taken a hearing test before, you can think it's really challenging to just sit and focus and think, is that the softest sound here? Can I hear it softer? And you're really kind of focused on this test, and we're asking infants to do that. It's much more challenging that way. So we observe these as minimum response levels and not necessarily a threshold of hearing. So we're assuming that their responses that we do get consistently are likely super thresholds, and their hearing may be just actually better than what we're getting in the booth. The next test we transition to is our visual reinforcement audiometry. So we go from BOA to VRA. VRA is most commonly used at 5 to 6 months and over, probably anywhere between 5 to 6 months till about, I don't know, depending on the development of the child, could be anywhere from 16 months to 2 years old. We can do this test when the child is developed some core control to sit upright. They can either sit independently in a high chair or they can sit on a parent's lap, but they do have to be able to sit upright and not just leaning on their parent. The goal of this is we actually want to train the patient to laterally respond to sounds left and right of them. And we can reward them using some visual reinforcement. So this is either with a TV, with moving puppets, with lights. Some clinics are really creative in having different tools. Our clinic setup is that we have the patient sitting in the middle of the booth, and we have a TV to the right, a TV to the left, and then we do have a TV in the center, but we actually use a clinical assistant to center our children. And it really takes a fine skill of being distracting, but not too distracting, to get really accurate results on these children at this age. So a self-polling question here. When you see an audiogram that looks like this, and just to orient yourself, we use split audiograms. It's very silly here, but if you ever seen this symbol, which I'm pretty sure made up, sometimes more often than not, it actually is this symbol. What does this symbol actually mean to you? Because I know that when we give this to our ENTs, some of them may not even know what these symbols mean. And so the questions here may be, is it these right ear responses? Because we plotted them on the right side. Are they sound field responses of the right ear? Are they sound field responses of the better hearing ear? Or are they possible responses from the right ear? And if you're self-polling, the correct answer is C. And if you take home anything from this lecture, is that anything obtained in the sound fields is not ear specific. In fact, you can have a child with single-sided deafness in their right ear, and you may present it out of the right speaker, but their left ear is very capable of hearing that response as well. And so if you take home anything, is that anything obtained in the sound field, so when we're using those free field speakers, it's not necessarily ear specific, unless one other situation, which we'll talk about in just a moment. But the beauty about this test is that it can be ear specific or not. And so when we have children who have aversions to their ears being touched, this is a really good test to at least have an idea of how their better hearing ear is responding. So in the best case scenario, we can assume, well, they at least have a normal hearing ear by the testing that we obtained. So it's beneficial for those children who don't like their ears being touched. But the caveat is that we get limited information. So this is only reflective of one ear. And we see a lot of children with unilateral hearing loss, such as unilateral microtia atresia and ear malformations, where, if we do VRA on these children, it's just going to tell us they're hearing normal, but it doesn't tell us anything about how that malformed ear is hearing at all. So we need to get transducers on those kids as soon as possible. The beauty of this test is that we can do it with transducers in their ears as well. So we can use inserts, headphones, or even patients' ear molds, which oftentimes they're a little more comfortable wearing if they're already an established hearing aid user. And this can yield really valuable results on patient hearing sensitivity at a very young age. So we're able to get really good information on children using this as long as we have the proper tools in place. And while VRA can be completed in a solo capacity, so as one audiologist, and then I trust the parent to follow my instructions, our belief is that having a clinical assistant or a test assistant in the booth is vital. I am only as good as my clinical assistant who can help me in the booth. It's almost virtually impossible for me to be in two places at once. And so we find that this can yield in greater success in the patient becoming less fatigued quickly, because we have someone in there who's stimulating them with some toys and keeping them nice and distracted. So I wanted to show a video. This is of a girl. She is she's maybe 13 months old at this age. She has Stickler syndrome, so we already know that she has a significant hearing loss as well as a significant vision loss. And we are putting her in the booth. She has her own ear molds in her ears. She does not tolerate those soft inserts, and she doesn't want to wear headphones. She's very cute. And you're going to see how I communicate with our test assistant, who's John Carlos here. And you're going to see these responses from her.
This is pretty loud.
So we start with loud ones where we want to train them.
Hi, Matilda.
And she's not really responding.
Hello.
But it's important for that test assist to show them.
Bye-bye.
So sometimes the kids don't know what to look for, so we have to train them, of course.
If you want to sit and center her.
So I coach him to get in front of her, so she's not looking for mom anymore. And she turns on her own, which is really great. That would be more of a successful turn here. I can also show you sometimes we take chance responses and we don't necessarily discourage them, but if you see now, I'm going to actually switch to the left speaker and she's going to turn prematurely, but I'm still going to reward her because I was playing a sound at the same time. But then I want to make sure that she does respond actually without us giving mom as a cue or anything. So we repeat our responses quite often when we're doing this test.
Go to the left.
So I switch to the left ear.
Go round and round. Good job.
And she's quick. She does turn to her mom, but then quickly does look at the screen. So I give her that reward. And you can see he's switching up the toys, not being too distracting.
Wipers on the bus, go swish, 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 swish.
And good, she turns again.
Matilda.
And so we can do this at different levels. So we start really loud and then we start going down and we're searching when they respond and don't respond. And I will say it's an art because you can imagine how these children get fatigued very quickly. So we have to move fast enough and provide enough toys that are not as distracting, but still engaging enough so that the child wants to participate. And now I did mention that sometimes these responses are not ear specific. This is a child with charge syndrome. He's 2. The case when sound field responses can be ear specific. In his case, this is Jackson, and he's actually wearing a unilateral cochlear implant. And so in his case, these responses we're assuming are coming from his implanted ear. He's only wearing one. He's obviously not going to respond from his contralateral deaf ear at these levels. But we do this testing on our cochlear implant recipients, our hearing aid recipients. So this testing provides really foundation for really the future for these children. And so you can see without transducers on his head, how he also will similarly respond. Our children with charge, as you may know, have their multiple sensory impairments, and so very sensitive to a lot of things such as lights. They might either really like them or they have an aversion to them. And so sometimes he's not really stimulated by toys. He actually just prefers really kind of strobing lights.
Hi, Jax. Good job.
And you can see just him literally pull away and look. And we usually have the parent on the contralateral side just because we know that we don't want them to look in that direction. So if they do happen to look for mom, we know that that's a truly searching for mom look and not an actual auditory response because we're not actually playing anything to the side of the parent. And that's really for the little kids that we know will have maybe a tantrum if we take the parent out of the booth. So our next level of testing, which is probably the most fun part of our job, is CPA, which is condition play audiometry. I love this test. This is really just, you get paid to play with children. Although there is a goal at the end, so it's not just playtime on their terms. That can turn into chaos. We usually do this at anywhere from 19 months up until about age 5, really depending on the maturity of the child, the developmental age of the child. Our good indicator is when they can start performing play is if they're potty trained. That tells us that the child has the self-sufficient response of being able to follow an instruction, which is really good. But sometimes the condition play can be performed on children really young by performing such a very simple task, such as, say, you have a box of tissues and every time they play a response, we throw the tissue up and they let it fall down. I mean, kids can be stimulated by that for hours if they're young, of course. And as they get older, we have to provide more complex toys or something a little more entertaining, of course. The goal here, however, is to obtain a comprehensive audiogram, ear and frequency specific, with bone connection and word recognition. So what they're doing with adults, in maybe 15 to 20 minutes, we can complete on children less than 2 years old if you give us just about 35 or 40 minutes. And so if you're always wondering, what are they doing in the booth for that long? That's probably what's happening. And this is really dependent on so many factors that are out of our control, such as the child's compliance, their level of attentiveness, their comfort with the environment. So sometimes they're just afraid of being in the booth. So we try to add stickers to make it exciting, like a jungle or a rocket ship, and even their cognitive understanding of the task. So sometimes children just they can't be conditioned because they don't understand. We use many toys. And this is obviously not in the booth. This is actually a programming room, but like I said before, this testing is used as a foundation for all of the other things that we do with children. So whether it's programming cochlear implants, whether it's programming hearing aids, programming bone anchor devices, we use this as a foundational tool to have them make sure that they can respond with their devices. So this is actually after an initial activation on this little kid, and you can see this room is a mess. Oh dear. But that's really a sign of a successful appointment. In my opinion, it just takes a lot to clean and sandy wipe every single thing once they leave. What isn't a toy? Oh my gosh, my institution would fire me if they saw this photo. The Tim tips. I don't know how many times we will set up a patient and we'll step out just to go grab some tools or whatever, and we come back and this room is filled with toys. Our booths have so many toys accessible. You see the pig here, you see the monkey, cookies, vegetables, yet the parent always finds a way to find this closed container to give to the child. And then you walk in, the worst thing you can see is a child in a high chair throwing these Tim tips like they're sprinkles or confetti. And you're like, well, all you see is money signs on the floor. You're like, oh, we got to clean this up real fast. So, we have to be a little patient with these children, but know that things can be, we're creatively using everything as toys, except of course the tools we need to actually perform the test that we need to do. This video is of a child. The actual audio is a little bit off, but I wanted to showcase the video because it's how we train children to do condition play at a very young age. You can see she's under 2. She's wearing a pacifier in her PJs. This child has unilateral microtia atresia, and we're actually doing her aided testing with her Baha. So she has an earplug in her open ear, and she has her soft band on here. So we're doing this through the speaker. And this is the first time we got her to do some play, so it was actually really exciting. We do this approach called hand over hand, where the test assist will hold the hand of the child holding the toy. Then we'll play a stimulus like bop, 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 or we'll do ling sounds or something really loud. And then we'll get really excited about it, like it's the most exciting thing you've heard. And then you help them perform the task, whether it's put the coin in the piggy bank or put the cookie in the jar. So you'll see here. Cece, he's so excited. She gets really excited. She looks at me because she's excited. Yeah, the audio is a little off, but you can see JC gets really excited and she gets so thrilled. So now we're waiting for her to do it by herself. So I start really soft and I'm going louder and louder and louder until she gives me a consistent response. Yep. And so sometimes that just pull away and they're waiting for you to respond too. So they may not commit to the task, but they may be like, oh, they may get excited just like you did before. And so those are really good signs of a child that's well-trained to do the task. Now, of course, that's pretty much how we can encompass our pediatric testing. Beyond this, we do our traditional conventional testing, such as a conventional audiometry. Most of the children past age 5 can raise their hand or press a button. I personally, in my clinical practice, specialize in children who are under 5, and I work with children. Not only half of my clinical caseload is hearing aids, bone anchor devices, and diagnostics, and the other half is cochlear implants on children who are infants. So for my cochlear implant caseload, it's really the under 3 population. And for my hearing aid caseload, it's really the under 5. And the majority of my patients don't even speak English. So you can imagine there's a lot of creativity that needs to be pulled into these testing and a lot of patience. But I do want to kind of self-pull again, because this is really the crux that we haven't talked about yet. And I know even if your audiograms don't look like this, but you may have seen a response like this if someone was creative as we are. And our audiograms do have a cheat legend, but this of course is a symbol that is not on the legend, of course. So if you ever were to see an audiogram this way, what would you expect? What happened in the booth? Or maybe this was ambitious. I know this is my handwriting. I gave you maybe a sound field response. I put some 2 dots here. I did get a right and a left response though. I said this was good to speech and fair otherwise. So if you saw something like this, you may think A, that's not really an audiology symbol. B, it could be a possible response from the left ear at 2000 hertz. C, it's a masked air conduction for the right ear. Or D, no response in the left ear at 2000 hertz. You don't necessarily have to personally respond, but if you did not know, A, that is for sure. It is actually A. However, sometimes we, as audiologists, will make our own legend and then use it as a B. So it's a possible response or a one-time response, and we make our own legend in the bottom of the audiogram being like, if you see this speck, this is all I got. And like I said before, you have to have a lot of humility, especially with those difficult to test children, to give you something like this or something like this. Now, this is something that we must swallow our pride with. The way that our appointments are organized, especially children who are seeing us for the first time, they'll see audiology first and then see the ENT right after. And in our neurotology clinic, I could only imagine us turning in this audiogram to our neurotologist and him just shaking his head and being like, what did you just do for the last hour? And if you wanted to know what it was like testing a difficult child, because sometimes I can imagine that the neurotology consults are anywhere less than 15 to 20 minutes. And so the biggest objective there at that point, at least for a new patient, is, our neurotologists tell us all the time, my biggest task is to look in their ears. He's like, but you have to get actual information from them, which becomes a little bit more challenging, especially for these little kids. So yeah, when we see something like this is pretty much telling the neurotologist we spent 1 hour in the booth with the child and we got nothing. You got to swallow your pride with this one, because let me tell you, this one will hit you hard when you go to bed at night and just keep thinking about why things went wrong. And so there's really multiple reasons why things go wrong. Children are children. And so if you don't have the patience to sit and deal with it, then pediatric audiology may not be for you. But I just I revel in it. I love it. I will spend the entire hour with the child screaming if that's what it takes to get one thing out of them. And if I truly spent an hour and I got nothing, then that's really a counseling point, and at least it's an eye-opening experience for the parent to realize that maybe their child isn't as compliant as they thought they were. This picture I love. She looks like she's upset, but she's upset because we took away her iPad. This child has Down syndrome and autism. We have our speech therapist who actually works with this child routinely, so she's comfortable with her, hugging her and really holding her arms down while our clinical assistant is trying to put headphones on her because she has perforations in her ears and we really need to get some ear-specific information. The reason why we're holding her down is because she is punching herself in the face, so we don't want her to harm her face. And in these cases, this is the time when the parents are like, do what you need to do. I don't want to be involved. Just do what you need to do. Hold her down. And so most of the time we get the parents to hold them down, but this is usually a parent who was like, just do what you need to do. These children are very difficult to test. So we try our best, but we get what we get. Now, this kid, if you recognize him, he was the kid in that cochlear implant picture making a mess in the booth. But sometimes I want to showcase these next 3 videos of just when things truly go wrong, and we have these 3 spectrum of children. One, this is Lucas, when they just don't care to participate anymore. They just stop caring. And so we sometimes, when we perform condition play audiometry, when the testing is very long, so this was actually during his cochlear implant evaluation appointment where we need to obtain a lot of information on children, we usually try not to be very reckless, because then the kid thinks that they can do what they want to do. But in desperate attempts, the last test that we'll perform is that they can grab the toy and just throw it, right? So let off your anger, let off your stress, and just throw it. So they'll often throw it at the window towards the audiologist. And I don't take any personal offense to it, but that's actually the task that they were doing here. So they were grabbing the blocks, and instead of building something, our test assistant pulled the tabletop off the high chair and was like, fine, just chuck it. We have 3 more things that we need to do. We're just going to throw it. And so the kids love it. They love throwing things, and normally they're not allowed to do it. So this is a great task to do as like a last minute endeavor if you are obviously in a space where you're safe enough to do so. But then sometimes they just stop caring. So you can see we're doing some Ling responses here, and he just stops. So it's really loud. That's why he's plugging his ears. And normally Lucas should be throwing it every time he hears it, but instead he's just gently balancing it on the high chair. I couldn't help but laugh because his response is great. And this child just doesn't care.
Oh my goodness, too funny.
This is after, an hour and a half of us trying to get stuff, and he just doesn't care anymore. And this is truly when we got it. We were done. The child fatigued. We're done. In some cases, and probably the most common cases and the worst cases to sit for an hour with are those children who have extreme tantrums or extreme aversions to just being in our presence. And so I'll tell you, if you really want to dive deep into pediatric audiologists, you'll say this is probably our worst nightmare over here. I don't know if you noticed that tuk, 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 tuk response, but we call that the Hulk smash response. That's when they're trying to aggressively get out of their high chair. And really all we're trying to do here is just get OAEs. We're not even asking him to do anything. And this is him crying to just having the insert in his ear. And mind you, this is a normal, typical developing child with a speech delay. So this is really not fun for us either, if you can imagine. But when you see those big crossouts on our audiogram, it's probably because that happened. Or my favorite video, we just have straight up refusal to participate. So this is a bilaterally implanted child, and we're trying to get her to complete the ESP, which is the probably the earliest kind of speech test that we can do for children, just as they're recently implanted. She has other disabilities as well. But she's very specific on what she wants to do, and this is not it. So we're trying to condition her to the task, and she is deliberately hiding her head.
Ellie, we have to listen.
So she tells us she wants to play with another toy. Our poor clinical assistant is struggling. And so she uses it as a barter. We're not ashamed of this. We can negotiate. Okay, we can get the monkey. She just hides. Again, this is a task where we know children usually come after class, they come after school, they're tired, we're tired. And so sometimes we just have to call it quits. And that's really disappointing to the families, but it's really good to show them these things because sometimes they don't actually see it themselves. And you're like, well, she's literally hiding behind a sheet of paper. She does not want to participate. And we are not in any of the premise of doing anything by force because hearing loss is a lifelong condition for these children, and we don't want to scare them or associate any negative experiences with doing these testing. We want kids to get excited about coming into the booth and playing. We want them to be excited about being in the school jungle, and we often change our toys out so they don't get fatigued by the experience. But anytime we associate a child who's screaming and forcing them to do something is really just always yields a negative outcome. And so that's really a good segue into my last thought of, we're making a path for the future for these children. The goal of these tests is to pave a strong foundation towards a lifelong journey of audiology testing. Like I mentioned before, and my own specialties, it's not about just what they can do in a booth one time in an isolated snapshot experience. These tools are used to program cochlear implants. It's used to program bone anchor devices. And so it's used to test if these devices are working. And so it's not just that we need this child to do it once. We need this child to really develop and hone this skill so that we can reliably, make sure that these children have appropriate access to sound so they can develop appropriate speech and language. And so it's really important that we train them very young. And for the most part, we're pretty successful, but obviously I showcased times where it just doesn't work, and we have to be very patient with that. And we often find that as the child continues to get trained, this really helps with device use and retention. So when we see an increase in device use, we see an improvement in their ability to be tested. And then they also increase their ability to tolerate things at ear levels and their overall discipline. We have very poor behaved children, and that's because, their environment that they live in. And they're, I'm not here to be an enforcer, but we do have to play by our rules and not their rules. So sometimes these children come in and they think that they can play with whatever they want. And then they get mad because we tell them, well, you have to play the game this way. And then they just stop playing. And so it really is a fine balance and this fine kind of teeter-totter of trying to find this sweet spot for these children. But all in all, if we are consistently inconsistent in getting reliable information for these children, we can always refer for ABRs like we mentioned at our infancy stage. And like I did say, we could always do this on adults. Oftentimes we in this case, if they're older children and they're not going to sleep, we can do it under general anesthesia or sedation. Our clinic does anesthesia, but we can refer out for sedation ABR as well. The caveats of this is that we want to consider the medical involvement for the child and the risks of putting them under sedation or anesthesia. The time delay, so if you want an ABR on them tomorrow, that may not happen. It usually never does. It needs to get authorization, the OR, they need to go see their pre-op, all that stuff. And it doesn't account for progressive changes in hearing sensitivity. So an ABR is just a snapshot of how that child is hearing in that moment. So we have children with conditions that may be progressive, such as CMV or any other condition, we don't want to, we can't use that ABR as this fine gold, and we can't use it for a year. So sometimes we will say, well, this ABR is valid for a year for a very difficult to test or multiply involved child, but when they have a certain condition that may have a progressive loss, that ABR is only good for that day that you did it, unfortunately. And so we really have to be creative in trying to get these children to get something out of them, whether it's an eye blink or something, so that we're not solely relying on objective measures such as an ABR, because in the pediatric audiology world, our behavioral testing is really our gold standard of testing. And so all in all, our pediatric audiologists, some of you may think we're just, some clinicians, some things that we're glorified babysitters. Some people can consider us magicians. Our clinic considers us unicorns because it's really hard to find somebody with that much patience. But really, our dedication is for these children and making an impact for their life. And as long as we can do that successfully, we're in it for the long haul. And that's all. My email is here. So even if there's not any active questions here, I can, of course, you guys can feel free to email me if you have any other questions. But that's pretty much it. Stop sharing my screen here.
Thank you very much. That was great.
Thank you.
Really appreciate it.
So if anyone, even if I know the crowd's pretty quiet, so I don't have to, it doesn't have to be painful if they don't need to, but you guys can feel free to email me if you have any questions. I'm more than open to answering anything.
Thank you.
Thank you. I really appreciate for this opportunity to be hosted.
Glad you helped us out. Thank you.
No problem. I hope everyone has a good day.
You too. Stay safe.
Thank you. You too. Bye.